Thank you. Thank you. Okay, my name is Bonnie Flemster, and I'm a geriatric nurse practitioner. Okay, I have worked with people like you in nursing homes since about 1985. Okay, I know what you do. I want to know who the aides are in here. Who are my aides? Okay. This program is especially for you, okay? Because I know who the eyes and the ears and the hands-on for these residents every single day. I know who does that. So when you talk about change of condition, it's you, it is the aides who have the most frequent contact with these residents. So what we're going to cover today is changes in condition and how to help you notice those acute changes. And acute means things that haven't happened before, something new. For pain and for activities of daily living, and then how to continue to watch them and how to care for them, and then for the nurses, all of that, because you're responsible for all of that, and notifying the physician. The residence care plan, the care plan, okay, and I know that it's the nurses who write the care plan, okay, but the aides should know every single intervention or every single goal for every single resident who's admitted to this nursing home. So that care plan starts just as soon as you get that resident admitted. The initial assessment's made, a nursing diagnosis is made, and then nursing orders are developed. So the nurses look, they see nursing problems, okay, and they decide what they're going to do about them. And then the nursing assessment continues in any new problems, because trust me, I know that when you get a resident in here, you don't have a clue what all the problems are, okay? And then the other thing you do is, as you're looking at that plan, is it working? And then a written nursing plan should be part of every resident's chart, and everyone in here who has contact with that resident is responsible for knowing what's in the plan. That's not the nurse's plan of care. That's the resident's plan of care. It's not the doctor's plan of care. It's the resident's plan of care. It's how we take care of every single resident. So the suggested assessment is that you look at the resident, what's going on with them now, and you identify as many of the problems as you can, and then you start to look for the problems that you may not have answers for. The problems that you can almost expect to have a poor outcome, and then watch out for those risk factors that lead to a poor outcome. So for instance, you have a resident who comes in with heart failure. Okay. You know what the signs are, pretty much what the signs are if the resident starts going bad. Okay. You're going to be more short of breath. You're going to have a harder time walking to the dining room. Okay. So those are the things you kind of focus on. Your assessment, the first step, is you pay attention to what's going on right now and compare it to what was going on yesterday or even this morning or 15 minutes ago, okay? And you say, is there a difference? Is there a change? Because if you see those little changes, then they don't turn into big things. The key to assessment is asking the question, what is the difference? You know, I know I'm a nurse. I help you take care of people. And sometimes you just know there's something different going on. There may not be a change in the vital signs. There not be a change in anything that you really can say there's something different. You just got that feeling that you know there's something going on. Pay attention to that. Then you say, why is there a difference? And then when you have the answer to why there's a difference, then you're pretty much set to figure out what to do. So your assessment includes vital signs. Do aides take vital signs here? Nurses take vital signs. Who takes vital signs? Med-aides. And nurses.
Yeah.
Then you look at the mental status. Now it's the person that has the contact with the resident the most is going to tell whether there's a little bit of difference, okay? And I know sometimes, I've had doctors do this, you have somebody with dementia, and you say, they're confused today, and you get the answer, well, they got Alzheimer's, of course there's confusion. But we know when there's little differences in that confusion. What's their major diagnoses, what their allergies are, what medications they're on right now, what their recent lab is, and the actions that you've already taken. It's important to know what's going on and what have you already done about it. And then do they have a no code? So changes in any activity of daily living is a change of condition. You hear me? If they're not eating the same as they did yesterday, if you're having more trouble giving them a bath, if they help dress themselves and now today they're not helping, if they have bowel and bladder problems or any change in that, okay? Do they usually have a bowel movement every morning and now it's been a couple days, okay? Or are they going to the bathroom, are they urinating more frequently? Are you having problems with them transferring? Do you notice a difference in how they're walking? Are they holding on to the railing more than they did yesterday or the day before? Acute assessment. When an acute change occurs, you hunt for the cause. If there's a difference, if there's a change, what's causing this? And then you review any changes in the treatments, any changes in their medications, any changes in their labs. You review any changes in their activity of daily living. If they're having trouble walking down the hall, then you need to say, gee, are they having trouble eating? You know, are they having trouble paying attention to what I'm saying? Pay attention to their medical history. Why? That's the question, why? You have to interview every resident as they're able. You interview the staff for any identified changes because we're a team. You know, sometimes people here in the dining room, the dining room people who help you serve and clean up, they can pick up on things too, and they should feel free to be able to come to you and say, you know, Miss Jones is having a hard time getting the spoon up to her mouth, and she wasn't like that before. Or Mr. Jones is having more trouble trying to find his place at the table. We need to talk to one another. When you do an assessment, you need to do a physical assessment, which means that you look at them. You look at their bodies, you take their vital signs, you check their neuro, you listen to them, nurses need to listen to their hearts. You need to check their abdomens, you need to look at their recent lab. When did they have their last BM? When was the last time they voided? Is there anything unusual with their stool or their urine? Is their urine more cloudy than it has been? Does it now have kind of an odor? Okay. A change of condition, any problem that's not already in your plan of care. Remember I told you aides are just as responsible as everybody else to what's in that plan of care. And then what in your best nursing assessment needs to be reported to the doctor. And we'll talk about nursing assessment in a bit. I'm guessing this is tag 309. You and the facility, this is what the state says, this is what Medicare says. Okay? You and the facility must ensure that the resident obtains optimal improvement, means they get better the best they can get, okay? Not compared to anybody else, but the best they can get, and then that they don't deteriorate within the limits. They can get sicker, but it's within the limits of their right to refuse, which they have that right, and then within the limits of what you recognize as their, whatever their particular sickness is, and the normal aging process. Your resident who are most at risk and need your care, there are certain residents that you know you need to focus on, and those are the ones with dementia. Those are the ones at the end of life. Those are the ones that have fecal impactions, okay? Those are the ones that have diabetes, who have fractures, who are in pain, who have heart failure, skin problems, and kidney problems. And that's a big list, and that probably covers just about everybody in here. So the common types of pain in the elderly. Okay, acute pain. Acute pain is a pain that starts, but it should end as soon as that person heals. Okay. They have a broken hip, they get a hip replacement, they're in pain, but as they have therapy and they begin to walk again, that pain should go away. You need to know that pain has absolutely no value. It has no purpose at all. The only purpose of pain is to tell that there's something the matter. That's it. And in acute pain, sometimes there are changes in vital signs. They breathe faster, their blood pressure may go up, their heart rate might go up. And if you don't address those changes, and a lot of times it's the patients with the hip fractures, okay, that's the ones we seem to get the most. If you don't take care of that pain, that can cause permanent damage to their central nervous system, and they will have pain for the rest of their lives. The current recommendations are that you give them that pain medication. It's not up to you to decide whether or not that resident needs pain medicine. Pain is what the person says it is when they say it is. And I know there's a lot of questions about opioids now and people getting addicted. But you know what? If someone's 80 to 85 years old and they're in pain, I actually had a family member come up to me, and the gentleman was 85 years old, and I put him on a opioid. And the daughter was hysterical because he was going to get addicted. And I said, you know what? Let's just take care of his pain now, and when he's 95, we'll send him to a drug treatment program. So you need to treat that aggressively and work with the other healthcare teams. Okay, now we have chronic pain, and chronic pain is a pain that just comes with it and doesn't go away. You don't expect whatever it is to heal, okay? And so those are somatic, and those are arthropathies, which are, you know, arthritis pain and gout and back problems and neck stiffness and headaches. And then there's visceral pain, which is what goes on inside with the skin, ulcers, non-inflammatory ischemic disorders, or which when somebody doesn't have enough blood flow to their legs or their arms or the stomach, they have pain. And then there's neuropathic pain. Mostly what we see here in nursing centers is polyneuropathy with diabetics. Okay. And then post-stroke often has pain. If somebody's had post-traumatic neuralgia, okay, and then any kind of spinal problems. What you need to know is that when someone is in chronic pain, they very seldom have changes in their vital signs. So you can have somebody who's really, really hurting from their arthritis, but you're not going to see a change in their breathing or their heart rate, okay, or their blood pressure, because the body just becomes accustomed to it. So pain in the elderly. 5 to 8 people out of 10 of those people you know who are over 65 are in pain. Okay, and I'm not just talking about here in the nursing home, I'm talking about people you go to church with or you see in the grocery store. Half of them are probably in pain. 32 to 36% of older people in the community, okay? 1 out of every 3 people in church are in pain. 60 to 70% of nursing home residents have significant pain, and 1/3 of them are in constant pain. It never goes away. And we wonder why some of our residents get cranky. 66% of geriatric patients have chronic pain, okay, and only 34% of the time, okay, out of 100% of the time, only 34% of the time do we even notice that these residents are in pain, okay? And a lot of times, the doctor doesn't know about it because we don't tell him about it and they don't get treated. And then there was one study in the Journal of American Medicine that said nearly half of elderly patients with cancer are in daily pain. Okay, you need to know that pain is the #1 reason people go to the doctor. It's the #1 reason. And pain is the most feared complication of illness. Anytime that you know this with your family members, anytime they get a diagnosis of some kind of an illness, the first thing they think about is, am I going to hurt from this? They get a cancer diagnosis, am I going to be in pain? Pain is often underdiagnosed and undertreated. Pain affects mood, functional status, and quality of life. If any of you have ever had pain after a surgery, or have a real bad headache, or stubbed your toe and it really, really hurts, it's really hard to focus on anything else. And then pain is associated with increased health service use. Okay, now that makes sense. If pain is the #1 reason why people go to the doctor, of course it's going to cost money, because that's why they're there. So, what happens if you don't treat the pain? Well, they're going to have a poor appetite and weight loss. You don't sleep well when you're hurting. You withdraw from talking or social activities because all you can think about is how bad you hurt. You can get sad, anxious, depressed. You can get verbally aggressive. And we see that a lot in nursing homes, where they begin to wander, okay, or they act out, or they don't want you taking care of them. They don't want you to turn them, they don't want you to move them, they don't want you to do anything, just leave me alone. So when you have a resident like that, stop and think, is it because they're in pain? And then if they have a Tylenol order, give them a cup of Tylenol and see if it helps. It's a PRN pain medication. If you think they're in pain, you can give them Tylenol. The other thing is they have a tendency to get skin ulcers because they don't want to turn. They're incontinent because they don't want to get up and go to the bathroom. They're at increased risk for chemical and physical restraints. Thank goodness we don't tie people down much anymore. They don't want to go to the activities of daily living. I promise you, if you have someone here who goes to bingo every day and one day they decide not to go, there's a problem. Okay. They have impaired immune function. They're more likely to get infections. So what do you need to do? The first thing you need to ask is, what is causing the pain? You can't fix it if you don't know what's causing it. The pain location and influence on function. Okay. When are they having the pain? And if they are not moving around, is it because they have a wound? Pain behavior, how do they act when they're in pain? And then assessment of the pain medication. Okay, so monitoring pain treatment effectiveness. You've got pain scales, I'm not gonna go through that, and there's even a different one with someone with dementia. Use an appropriate tool. When do you do it? You should look at that, you should look at the resident and ask or check if you think they're in pain at least once a day. It's your responsibility to check at least once a day and concentrate on, is my resident in pain? At least once a day. You should always check after giving pain medication to see if it worked. And then with any medication change, you should check. With changes in condition, any change in condition, if they're not walking, why aren't they walking? If they're not eating, why are they not? Is it because they're in pain? And then someone has to be responsible for checking on it. Who's going to monitor? And then the results of monitoring should be in the record. So reassessment of all components, which means that when you're checking to repeat, if someone's been in pain and you've treated, you need to go back and check exactly what you did before to find out if they were in pain. And pain should be assessed on regular intervals. And then if you have a resident who's asking for more and more pain medication, you need to pay attention to that. Okay. PRN, I had the doctor that mentored me when I became a nurse practitioner, he said PRN, pain medication, means pain relief never. PRN, pain relief never. Because we wait until the very last minute to give this pain medication, and they're in such bad pain that they become anxious. And the more anxious they become, the worse the pain gets. And then you give them a pain medication, and it helps, and then they start worrying, am I going to start hurting again? Okay. So try to get your PRN pain medications on a routine basis so that they never begin to hurt. So if you have a wound, what's causing the pain? Is it tissue damage? Is it a constant stimulus, like a drain or a Foley catheter pulling and straining? A lot of times we put tape on somebody, put on a dressing, and we wrap it too tight. Chemical irritation, ulceration, friction, okay, which we scoot them up in bed and take their skin off. Sutures and stretching, okay, a lot of times, I bet you every one of you have had somebody that had some kind of surgery, and when you finally got the sutures out, they went, oh, that's so much better. Because those sutures were pulling the whole time. And an immune response, when somebody gets arthritis or they get a urinary tract infection, okay, they're going to be in more pain. So let's talk a little bit. One of your problems was with Foley catheter. So let's talk about catheters. What the purpose of the catheter is to drain urine from the bladder into some kind of a drainage bag. Okay, and you can see from this picture, that that balloon rests inside the bladder and keeps the urine from coming out, so that the only way the urine can get out is through that tubing. Okay, you need to secure the tubing to the resident's body where there's no tension. And there's a lot of ways to do that. There's different ways, there's different things that the facility can buy. You can use tape, okay? And if a male, you need to secure that tubing so that it isn't pulling on the penis, because this is what can happen. Oh. One of the best things that you can use is something called a belly bag. I don't know whether you've ever seen those or not, but they're very helpful, and that keeps the penis in a position where there's no tension and where the tubing isn't pulling, literally ripping that skin. So there's different ways. One of the problems with Foley catheters is that they cause infection. And there's different ways it causes infection. You can get bacteria on the outside of the tubing, but you can also get infections on the inside of the tubing if you're not careful about how you connect it, okay? And the other thing is that you have something called biofilm, okay? Biofilm is slimy stuff that just collects, that's one of the things the water company worries about all the time, and they put chlorine in the water, not just to keep you safe, but to keep that film from forming on the inside of the tubing, inside of the pipe, water pipes, okay? And that's a dog's water bowl. I'm sure that you've seen that slide. But you can also get it on wounds. Okay. See that wound? That's biofilm. And on teeth. Okay, you can also get incrustation on the Foley tube because you've got chlorine and chemicals in your urine, and it causes crusts. So Foley catheter review is always wash your hands and use hygiene before and after any contact with the Foley catheter system. I don't care what you're doing, you just need to wash your hands and use alcohol. You need to be really careful when you insert that Foley. You need to secure the Foley catheter to the body without any tension at all times. Okay. And even, women, you need to anchor that tubing to their thigh or someplace on their body so it's not pulling constantly. You need to keep the catheter bag below the level of the bladder at all times. You need to maintain sterile as much as you can. Don't let that drainage bag get too full because it can back up that tubing. You need pericare daily and after any incontinence, stool, or urine. Specified criteria for insertion. You need a policy here and why you need to keep that Foley catheter. Because if someone has a Foley, they will get the urinary tract infection. Period, paragraph. They're going to. So watching for change. The key to a change of condition is always to be watching, paying attention. Residents should be watched wherever they are as much of the time as possible. Not just in bed, not just in their room, when they're walking down the hall, when they're going to the dining room, when they're eating, okay? You pay attention to them. Watch what they're doing. You check in with the residents often and talk with others who help you take care of those residents. I know how this goes. Sometimes residents like one of us better than the other of us. Or they like the other of us better than us. And that nurse or that aide can get that resident to do something that you can't get them to do. Okay. Find out what the secret is. Or trade places and you let them do it or you do it. Okay? Because you're a team. Detecting change. Know what the normal baseline is. And it's really hard when you're a new hire to know exactly how that resident behaves and how they act. But ask. Know the resident's ability to move around. Know how the resident does activities of daily living. Knowing the resident's preference for activities, eating, and dressing. Change of the resident's normal condition can signal a medical change. If they're not acting the same, they may have some kind of a change in their medical condition. Probably do. So problem identification is the nursing process. How you look at the patient and how you assess them tells you what problems they had. The next step is, with the planning, is you get input from the other providers. Okay. Ask PT what's going on. Ask the dietitian what's going on. Ask the people who work in the dining room what's going on. It will focus on the residents' desired outcomes and compare your assessment with the existing care plan. If you see a problem, I don't care if you're an aide and you think that you don't contribute, you do contribute. And you can identify problems that the nurses may not be able to identify. And I promise you, everyone in here can identify a problem the doctor doesn't know about. And is there a difference from what's usual? And if it's not what's usual and what you see every other day, it's a change in condition. Do you hear me? If there's any difference, it's a change. So you document. In the detailed nurse's notes, you need to tell what the resident's change is, describe the actions and describe what you did. Okay. Here's the problem, here's what I did about it. Interventions can be just as simple as giving a PRN medication, changing their position in the bed, helping them walk down the hall, helping them cut their food up. Okay. That are getting new orders or transferred to an acute care hospital. Okay. Sometimes we have to send them to the hospital. So when in doubt, report a change. Okay. You don't have to be positive about it. Report it. Tell them. Physician notification. There's two kinds of notifications. Some things can wait till tomorrow, and then there's other times when they need to know right now. So notification of change, these are the things that are in your policy. Anytime there's an accident resulting in injury, that needs to be reported within 24 hours, except I have an addendum to that in a minute. And then any acute illness, any change that you think they're getting sicker, any need to change the treatment, anytime you need to transfer or discharge a resident, and whatever expected. Okay, this is new. I went to an 18-hour dance program, and there's been a lot of changes that you'll see happening with abuse, neglect, and exploitation. And one of the things is any injury of an unknown source or misappropriation of a resident's property has to be reported immediately, not later than 2 hours if it results in the body harm. If that resident gets hurt in any way and you don't know how it happened, that needs to be reported within 2 hours. Okay. And no later than 24 hours, and that's already in your policy. Okay, nurses should not hesitate to contact a physician anytime for a problem and their best assessment requires immediate attention. And I'm going to tell you a personal story about that. I was working in ICU and had a patient who went into VTAC, ventricular tachycardia. That's lethal. People die from that. So I called the doctor and I said, and this doctor and I got along pretty well, and I said, I think Mr. So-and-so's in VTAC. And he said, Bonnie, is he or isn't he? And I thought, why is he questioning me? You know, I'm certified in this. He ought to know that I think he's in VTAC. He's in VTAC. And I said, well, I think so. And he said, okay, I'll be right there. So he came over from his office and examined the patient. And the patient was in VTAC, but that's not important. I'll tell you why. Okay. So I went up to him afterwards and said, look, my goal for the day was not to upset you or to irritate you. That's not on my list of things to accomplish. So if you'll just tell me what it is that I irritated you about, I'll really try harder not to do it again. And he said, Bonnie, listen to this. I think Mr. So-and-so's in VTAC. Or, doctor, in my best nursing assessment, this patient is in VTAC. Okay, when I said in my best nursing assessment, that meant I looked at the monitor, I took vital signs, I did an assessment. Okay. Now, would it have mattered or not if that man was in VTAC? No, because in my best nursing assessment, I notified the doctor. And I'm telling you that the first step in the nursing process is assessment. And if you make an assessment, and in your best assessment, and you report it to the doctor, that's what you're supposed to do. Okay? Now, I don't know about your doctors here, but sometimes they can get cranky. Okay? So if you're not sure how this doctor reacts to your best nursing assessment, okay, and you don't have anybody else to ask how they're going to be, just put on your suit of armor and call that doctor, because it's much better to be chewed out or fussed at than have a patient go bad and die because you didn't have the nerve to stand up to him. Okay. So before you notify the doctor, you need to get all the information before calling. I'm a nurse practitioner. It used to make me crazy when someone would call me and they'd say, well, I think Miss So-and-so's got a urinary tract infection. Well, what's her vital signs? Whatever. Well, the aide said her urine smelled bad. Okay. I need more information than that. Okay. So what you do is you have the chart in front of you. You have the medication list in front of you. You have vital signs, okay? And any pertinent lab, you accurately assess and document in your best assessment the problem causing the change of condition, okay? I believe Mr. So-and-so, in my best assessment, Mr. So-and-so is having problems with his heart failure. And I believe it's because his family brought fried chicken and potato chips, okay? If the resident has pain, you need to say what relieves the pain and how that pain affects the resident. You anticipate the questions the doctor might ask. Okay, they always ask the same thing. Be prepared to answer it. And if you've not worked with that doctor before, ask the nurse beside you and say, what's he usually want to know? If the doctor must return the call, for heaven's sakes, be available, or tell whoever is at the desk where you're going to be so they can get hold of you right away. When you call, say who you are. What's your name? My name's Bonnie, and I work at so-and-so nursing home, okay? And the resident, and which resident it is. I'm calling about Mr. Sam Jones, okay? Now, if the doctor you're talking to happens to be on call, be sure and tell them who the primary doctor is, because they talk to one another, and they'd be much happier knowing who the other doctor is, because they know what the other doctors would do if they answered the call. You need to summarize the resident's condition. Why are you calling? Okay. Why are you calling? And there's a reason for it. Has there been a change in their activities of daily living? Has there been a change in the vital signs? What have they not responded to some treatment that you've given, whether it's wound care or changed their diet? Your nurse's responsibility is to monitor and reassess that resident's status in response to the plan. Okay. Once you're supposed to know what the intervention is, you're supposed to know what the plan is. Stick to it. It is okay to ask the doctor, what do you want me to do? Okay. You call about somebody's in heart failure, what do you want me to do? What to expect, what to monitor, and you continue until that problem's solved. Okay. You do what the doctor said to do, and it's working fine. If it isn't working, you call it in. If there's no resolution, You continue with the contacts and the interventions and communication with the doctor until you get a satisfactory result. And if you can't get a good result from the doctor, make sure your director of nurses knows. And even if you have to go to the administration, and maybe they have to go to the medical director, okay? The physician's responsibility is they have to come up with the diagnosis. They need to come up with what to do. They need to tell you what to do. They need to guide the nursing staff. What to expect, what to monitor, and when to contact them. You know, that's one of the mistakes we nurses make is we don't say to the doctor, if this doesn't work, when do you want, how long do you want me to keep working on this? Okay. If the resident remains in the facility, that's a change of condition and you need to update the plan of care. You need to document, you have to tell what happened, what change happened, and why you needed to send them to the hospital. You need to chart all the interventions, you need to say when you called the emergency, when you called the EMS, what time they got there, what time they removed the resident. And then you always notify the responsible party. And you need a doctor's order to transfer. Okay, always remember that. You can't do that on your own. You document in the resident's chart all the attempts you made to call the doctor. Okay, all attempts. You are not responsible. The doctor has his own insurance. You don't have to worry about the doctor. Okay, you don't need to protect the doctor. The doctor's perfectly capable of protecting themselves. If you had to call 3 times, you chart. This is the 3rd time I've called. Okay. You have to record what the physician's response is. If the physician says, I know about this, don't call me again, you chart. Physician said he knew about the problem and not to call again. Okay? You need to chart the physician's orders. You need to chart what the patient's status is and how they responded to that order. You need to, if the resident transfers to the hospital, you need to do the transfer form. You need to send a copy of the advance directive. This is really getting more and more important. Listen to me, okay? If they have a DNR, you must make sure that that goes with them. I've read 2 lawsuits now, okay, where there was a DNR and it didn't get sent to the hospital and they resuscitated that resident and then the nursing home got sued and so did the hospital, okay? You need copies of any lab or x-rays. You need a list of the medications to send with them. You need their most recent history and physical. And when they come back from the hospital, this is a change of condition. You cannot go back to the same plan of care. Okay. Whole new ball game. You need to carefully read the admission orders. Are there any changes? One of the things I want to tell you though is a lot of times your Alzheimer drugs are not on the hospital formulary. And so they get DC. What you need to know, if that resident is on an Alzheimer's drug, the time that they are off of that drug, they will never get that time back. If they deteriorate, which is what's going to happen when they're in the hospital because they're sick, if they deteriorate and they will, even if you restart that medication, they will never be back to where they were before you sent them to the hospital. And if you don't pick that up, then they don't get put back on that medication and they're just going to go downhill. So watch for those drugs. Watch for any of the drugs the resident was on before you send them to the hospital and find out why they're not back on them, okay, or whatever substitutes were made. If they now have a DNR that needs to be noted, there'll be changes in the meds. You should demand a history and physical and a discharge summary. You should demand one. Good luck with that, okay? But you should have what they did to that resident in the hospital. Their skin condition, do a Braden, assess for new wounds, because I know where they get those wounds. I know where they get the pressure ulcers. And it's not because they don't get good care in the hospital, it's because they were sicker. They had more risk factors. And then assess any previous wounds, okay, and compare them to what they come back with, and make sure you document that really well. And assess and obtain any changes in the wound care orders. Okay, do you have questions? Okay, time to take your post-test. Thank you for your time and attention. I really appreciate it.